My name is Nara Murillo. I'm the host of Agewell Avenue podcast, and my co-host is Barbara Slingloff.
On this show, we talk about navigating healthcare, housing, investing, and advocating for our seniors.
Nara, in our last podcast, you were sharing about going to school, nursing school, and what I'm hoping is that you can share now. You've completed nursing school, and what happened to you after you graduated. Maybe you can share that.
Yeah, so after my graduation, after 2 years of nursing school, and you know how nursing school is, it's a completely different experience. It gets you ready for other things in life. But I think, for me, it was really just excelling in whatever I did, right, in nursing school, because it was, I was going to have people's lives in my hands. So it was very, very important for me to know everything that I needed to know. And so, but after graduating, I actually got a job at CAP Management Systems, which now it's Conifer. And I actually started there as a temporary nurse. It was a temp job that I took because at the time my ex-husband had lost his job. So I needed to get going and working. And so, so I took it. I took it, I said, whatever it is, I'm going to, make it work. And so I'm going to learn and whatever this looks like. I had no idea at the time what case management was, utilization management, none of these things. And so it was almost like I was meant to be in this space. And so, as we all know, being in nursing, there's just so much that you can do, but this is kind of where I kind of landed and ended up kind of adding to my knowledge and growing in this area. So basically what I was doing there at first was case management. So for a very short period of time, I did case management. I was managing a lot of patients with chronic conditions. And then after I did that, and they transitioned me to concurrent review. So, and then after I was working with them for, I think, a couple of months, they actually offered me the job. They extended my contract first, and then they offered me a job there, a permanent job. So, of course, I took it. And I was there for 2 years. I stayed there for 2 years, and I did a little bit of, everything from utilization management to I was working on pediatric cases, CCS. California Children's Services is basically a state program that almost I don't know, authorizes certain diagnoses that if they have certain diagnoses, then they will step in and basically pay the hospitals for the payment instead of the insurance is basically paying for it. So it was really, really interesting, very, very good learning experience for me. I learned a lot. And in case management, obviously, how to, when you're managing a patient, short-term, long-term goals, right? So we set up short-term and long-term goals for the patient based on their condition. And then ultimately we reach those goals, and then eventually they graduate from the program and we don't have to follow them anymore. But basically that's what I was doing there. I think the importance of, in the concurrent review side, the importance of not keeping patients in the hospital for a long time was really the key. And understanding, when is the acute need end in a hospital setting, and that's where you really need to identify those things to confirm, to make sure all these things are being done appropriately in the hospital, and just the follow-up and management of it all. And so it was just a really good overall experience for me. And even though I didn't have a lot of floor experience, in the case management, I just learned so much, I mean, I applied whatever I had learned in school, of course, but I think that I think it helped me in a sense, because when you're coming from floor nursing to case management, it's very different, because you're basically used to treating patients. You don't care about insurance. You don't care about what qualifies. You don't care about any of those things. You just make sure that, the patient is taken care of, right? But with us, it's not only understanding that there's a patient that you need to care for, but at the same time, you're understanding the money side of things, right? On how they run the business side of things, and on the back end, how this all works. So I think that's pretty much what, it really kind of gave me a foundation, I would say, there. And then how to manage costs and things like that. So it was just an overall amazing experience for me. And then from there, I went to work for I wanted to kind of dive in more into pediatric population, because I just thought it was fascinating, right? Like understanding the whole California Children's Services and how they applied certain diagnoses. And so I think that was really fascinating to me. So I went to work for a company that um, it was a all Medi-Cal line of business. So it was basically all children. It was a pediatric population only, and I think the biggest thing for me was I only stayed there for 2 months because it was very, very poorly managed. I always talk about how management can either make some place or break some place, right? And so that was one of the things that I saw. It was just a nightmare. It was, you know, um, I don't think that I had ever seen. I mean, I have intimidated people before, but this was just to a very different level. And the lady that was kind of overseeing things, with the case managers, she had been there for a while, and she literally would shout over, between cubicles. Like if there was something that needed to be said, she would just shout, and I was on the phone with patients. And so so I was like, this is unacceptable. I will not work in this environment. And so I spoke to the leadership, and they wanted me to move my seat. They wanted to move my seat where I was sitting, so I wasn't next to her. And I just said it's unacceptable. I shouldn't have to be doing that. Someone's bad behavior shouldn't have to, you know, make me move, or, basically you're avoiding it and not addressing the issue. And you're allowing someone to behave that way and get away with that. And especially as a clinician, right? We I think we expect more, right, in that sense. So anyway, so I ended up leaving. I just could not work in an environment like that, nor even be productive to help people. And so I went to work for AIDS Healthcare Foundation, which was basically, I was doing concurrent review there, and it was majority AIDS, HIV patients. I mean, that's pretty much what AIDS Healthcare Foundation is. So, and it was another learning experience, even though I was doing kind of something similar, managing them in the hospital, but it was very different population. I mean, this is a population that is immunocompromised, and they qualify to be at the hospital. So if you don't have the right provider understanding their care and on what's going on with their disease processes, there's just no way. They constantly qualify to be in the hospital. So I was working very closely with our provider. Our physician was rounding there, obviously, and seeing our patients. So it kind of made it easier. But I learned so much about just this disease alone, right? And how to manage it, and just the difficult discharges. And of course, even though we've come such a long way, skilled nursing facilities still did not really feel comfortable accepting these patients, right? And so we had specific skilled nursing facilities that I would constantly work with that were accepting patients, with HIV, because they knew, they were trained on how to handle them. But then, eventually you come to a point where they can only take so many. So then I would come across issues with, placement and things like that, right? If they needed a skilled nursing facility. So, but, it was just interesting experience, to say the least, of like all the critical values of lab values and things like that they would have, and, just how to manage that. it was very, very interesting, and I grew a lot. I learned a lot in that. So,
Do you
and
think
then
that the patients that you took care of at AHF, do you feel like they understood the challenges and that things were just more difficult for them? That resources maybe were not as plentiful, or once they got into the hospital, they knew it would be a while before they could get out? Did you feel like they had a sense about that?
yes, they absolutely did. And they knew that, being in that state, it was a very, very challenging thing. I mean, and a lot of them came with a lot of mental health issues, right? Because of it, because of not getting, better, or, they're constantly, as we know it, right? They're constantly being monitored, lab values, constantly going for blood work. And these medications were ridiculously costly. A lot of them weren't able to really afford, even though AHF had their own services. It was still expensive for some of them, and housing was an issue. A lot of them were estranged from their families. So again, there was a lot of mental health issues, but at the same time, having that right on top of everything else. I mean, they were just pretty much given up. Like, a lot of them had just given up. It was really sad. But luckily, AHF did do a really, really good job of, you know, um, helping them and assisting them, and they have really good programs and providers that really supported them. So I think I saw a lot of that, which was really refreshing for me to be able to say, I'm so glad that there's somebody out there that's able to do this for this population. You know what I mean?
And I think, as you share this historical past, I think what needs to be said is that the time period in which you did this work, obviously, since that time period, we've made tremendous strides in medications and the affordability of medications, how we treat the virus, and prognoses are good. Um, it gives people a different lifestyle than at a different time period where things were much more challenging. Do you find that to be true?
Yeah, yeah, no, absolutely. I mean, they've come such a long way now. I think they also provide housing now for their population. So I know that they're very, very resourceful, and absolutely, we have come a long way since then, for sure. And I mean, I don't want it to say it wasn't even that long, but in the span of, I would say 8 to 10 years, that absolutely, it's very different now, for sure. Um, and then, from there, um I came to PIH, and that was where my journey started with you. And so, I remember the interview like it was yesterday. And I think that I know I've shared this with you, but when I left, I just said I didn't get hired. I know I didn't get hired for this position. um, because I just felt like, even though there was so much that we talked about and we connected, but I just still wasn't sure if I was the right fit, and so, and of course, at the time when I got interviewed, it was for a skilled nursing facility position, and so I was supposed to manage skilled nursing facility patients, and so I didn't have that experience. I came with concurrent review experience, but I didn't have skilled nursing facility experience, so that's why I was kind of not sure about that part. And then, obviously, right, getting into it, it just kind of ended up expanding, my role expanding in, from skilled nursing facility to long-term acute hospitals, to concurrent review, to retro review and pharmacy, audits. So it was just a whole new world for me, obviously. And, this is where I got involved more in the health plan side of things, right? So, and the skilled nursing facility patients, I think, is when this is when I really fell in love with. I always had passion for seniors, but I think that doing this job really um, connected me to my purpose. I feel like this is what I love to do. When I would go see the patients in the facilities, I would always think, oh my gosh, I wish I could just put them in my pocket and bring them with me. Like, they were just all so amazing, and they always just were so happy to see me. They always just would just bless me every time I was there. I was always getting blessings, and I just felt like I was their voice, and so
I, I think in previous podcast, when you shared about being the waitress in the retirement facility, and I watched your face when you talked about that period of time and how much you enjoyed connecting with the seniors. I see that same face when you talk about working with this population of people and your passion. So when you say you connected to that and you really felt like that was your purpose, like all the dots really came together for you to put them all together and say, yeah, this is what lights me up. This is what's important to me. These are people that need help, and you were going to find a way to do that.
yeah, absolutely. And I think that for me, it was just like, I'm supposed to be on this path. I'm supposed to impact this somehow, one way or another. And so, and as I go down, more into my career, it just kind of will kind of tie it all together on where I'm headed and why I do what I do. But specifically, in this role, um, I started really getting involved in transitioning the patients right from the hospital to the skilled nursing facility. I would have conversations with the families, and I would, because we all know, right, skilled nursing facilities, between the hospital and the skilled nursing facility, there's a big difference. And a lot of people, without having any experience, think that this is just, like the hospital. It's supposed to be a post hospitalization care, right? It's a post, hospital stabilizing facility. But what they don't understand is it's a different level of care at that point, because you're not at an acute level of care, right? It's just post stabilization at this point. It's after the fact from the acute need. You're just basically getting stronger here. They're providing you therapy, and you're getting therapy 5 times a week. And so, yes, it's more often than your home health would provide it at home, but at the same time, it's still a different level of care. So just transitioning them, from that, and having those conversations. And some of the patients were going on hospice, right? And so having those conversations with the families and saying, and some of them were actually getting admitted to skilled nursing facilities on hospice, right? So because some families didn't want their loved one passing in the house, right? So a lot of them would just place them in a skilled nursing facility. So having those conversations, and I think it helped me grow so much, because obviously it's not an easy conversation to have when you tell someone that your loved one is passing, right, and they have a certain amount of time. So it's just being sensitive and learning how to deliver certain information to people, right, and understanding that it's sensitive, it's very personal, and at the same time, I had to be the strong one for them, right? I couldn't be feeling their emotions at the same time, right? So I had to be making sure that I was supportive of whatever decision that was, or they were going to make. But I wanted to make sure that I was that person that understood them and was by them, but at the same time, holding all of my emotions in place, right? Because I couldn't get emotional with them, right? Because I have to walk them through this process, right? Um, and I'm a big believer in that. And I think that's where a lot of my explanations and how I would deliver information and introduce it really, people were very accepting of it, because I was very much on that. I always believed in, nobody comes to this world in pain, and nobody should be leaving in pain. And everybody should be comfortable when they're leaving this earth, right? So I think because of that, I was always giving people options too. This is something that you can do, and this is, maybe it's not something that, if you decide to change your mind, that you can do that. And I think that helped people, to have those options. So so I think that was helpful for me to learn and, deliver.
Sometimes, um, because everyone can be from a different culture, or how families um, either talk about or don't talk about um, transitioning. And yet, if we're lucky enough to live to be older, how do we do that? And I think there's a lot of opportunity. And I think case management is really, even social work, are instrumental in helping um, plant these seeds. And it takes a while to get your head around um, things that you can see are progressing, let alone the things that happen unexpectedly. And education is so important because I think you talk about post-acute care. There's a language that comes with healthcare, and the average person doesn't know what that means. So when I'm in the hospital and I'm sick and I'm laying in the bed, and yet I'm not ready to go home yet, because if I live alone, I know I can't stand at the kitchen and cook and do my dishes and take care of my basic needs. So why can I not go to the skilled nursing facility? Why are they telling me I can't go? I think there's a lot of education that still needs to continue. And again, it's the language we use, and that's confusing to people, and it's not clear for them. And at the pace in which people are moving through the hospital, there's not a lot of understanding. And I think families don't have time to gather a plan. So I think your work that you did while you were at PIH and working with the facilities was so instrumental, because you were providing that education and you were planting those seeds.
Yeah, no, absolutely. And just being sensitive to all the different cultures, right? And understanding them too, right? And all of this takes time. I feel like, there's no one way of anybody taking in information, right? Every person takes information differently, and just being sensitive to that and understanding that, what, education takes time. No one's going to just, basically turn a corner in a minute and say, okay, yeah, I'm going to go with whatever you're telling me, right? You have to build relationships. And down the road, as I go into more case management that I did, it's all relationship based. And so that's what I've learned. And, my word is everything in everything that I do. It's all about, when I promise something, I'm going to deliver, and if I'm not going to be able to deliver, then I'm not going to promise that. Right. So it just sets, I think it just builds us, right, and as who we are as individuals. And it, those skills I think only heighten as you're doing certain roles and certain things that you go through. And but if that's what you have, and that's what you grow with, um, that's pretty much what you have. That is who you are, at the core of it all. So um, so I started helping the hospital and transitioning obviously a lot of these patients, and helping them, and being in meetings with them. It helped a lot, obviously, in transitioning, and making sure that the hospital also knew that there was somebody else taking that handoff, right, of that patient's responsibility, and going through the process of the transitioning that patient, right. So I think that it was a lot better. We had a better handle on it, so that the patient wasn't getting lost in the shuffle, obviously, because obviously healthcare can be very complex. But just and also I think the other thing was that with the facilities, I was very, very instrumental in making sure, teaching the case managers even at the facilities, right, of when does discharge start. Discharge starts at the time of admit, right? We have to understand what we're dealing with, even though the patient's going to be there for a couple of weeks. But those couple of weeks fly by, and we really need to make sure that wherever that patient is discharging is going to be a safe discharge. They have a place to go, and we have to make sure of all those things, and that takes time. So just very kind of working in collaboration with them, and understanding that, and letting them know about my concerns as well. Like, I had a lot of patients that, even though I was working very closely with a few of these facilities, and I had people complain. So I had to go in there and speak to the administrators and let them know, this is unacceptable. This is not going to work for us. If we're going to continue sending our patients to your facility, you have to, your staff has to perform better. Your staff has to do better, and just addressing those things and bringing those examples, I think, helped a lot. It was a very good collaboration between us and what our expectation was. And they knew, like, our bar was high. We needed to make sure that our patients were taken care of, and I think it needed to be said. And so then they kind of came around and started working a little bit more with us and understanding what our expectations are. And so I think our patients were getting a lot better care because they also knew we were on top of things, right? We were checking in, we were making sure. I would also go to, if a family didn't agree with the discharge, I would go to their meetings with the facility. And I would basically explain everything that, looking at the documentation, because I already knew what was going on with the patient. I would explain to the family that this is the situation and this is what the next steps would be. And a lot of times the families were on board. They agreed, they understood, where we were coming from based on information that the patient was, how well the patient was doing and all that. So it was a lot of, had great conversations and great outcomes, because of that. And just being involved, I think, families seeing that you're engaged and you're understanding and what's going on, and you know you having the knowledge you do, they appreciate that. They know they're
I think,
speaking with someone that understands it.
and I think um, what I observed as part of where you were so impactful during that period of time is that people didn't feel like they were discharged from the hospital and then now there's this new group of people and there was no point of contact and you're trying to figure out who are you supposed to talk to. You were engaged with the family, with the patient, and with the facility and the administrators, the social worker, everyone involved in the care plan for this patient. So I feel that that was a really pivotal piece, that when we transition somebody somewhere, that we don't just let them go. Um, and sometimes patients aren't let go of, but if families don't have a point of contact or they don't know who that is, um, it can feel like you're being abandoned in that, and you're not really sure what's happening, and you're trying to get information, and shifts change, and that person isn't here today, or whatever they may encounter. So I think you were really a great bridge and support to families, to the facility even. And I think um, this is where collaboration really began in and changing our relationships with all of our skilled nursing facilities, and developing a different type of relationship than was previously had.
No, absolutely, I agree. And I think that the the whole collaboration with the families and all of the different moving parts, right? It becomes really overwhelming for people, especially when you have a loved one that you're dealing with, and having that person navigate and help you through that process. And I think that's what people really appreciated. They knew that if they called me, you know I would have taken care of them, and I never made anyone feel like I only have an 8-hour day. And I think those days, I think we were working some ridiculous hours. I think we were finishing our days at like 8, 9 at night, and I remember I still had like an hour and a half drive home. And, but it was just so fulfilling that I never felt that I still needed to drive. I think that drive kind of decompressed me, right, from like my day of like having such a busy day, right. And so I think it was just so, um it fed my soul. I was just so happy doing it because I knew I impacted someone's life, and I helped a family, and I helped a patient, so it was just really fulfilling for me, for sure. And just the whole, transition from, even just custodially, right? Like if I had to transition patients to custodial live, like they didn't have any support, and so I had to, transition them in that sense. So we were working very closely with the skilled nursing facilities at that time, because we know, those things are very, custodial beds are not easy to come by. And so, but working with them and just very closely, and being able to do those things, I think, um, was just helpful all the way around. And just transitioning from hospital to long-term acute facilities. With the long-term acute facilities, it's a little bit different. Yes, you're managing them, but obviously it's a different type of management because they're still in an acute care, so you're not really actively that much managing them. So but I think that even that was interesting for them. Like, okay, what is a long-term acute facility? So what's the difference? Why does my loved one, why can't they be here, but then we're being transitioned here, right? So just the understanding of it now that they don't have that, we can't keep them here for a long period of time, but they can go here and stay there for a longer time to transition, so just explaining everything and helping them understand and navigate through the healthcare system, I think was really just I think understood my role and the impact I was making so much more, going through all these different steps. Um, and I think the only other thing that I was really into was the retro reviews. Like if they were, if patients were admitted, in another hospital and we weren't notified and I had to go through, I remember, oh my goodness, the charts that was on my the height of paperwork that was on my desk, just try to go through it and then review everything and make a determination and then go through it with obviously our medical director. And it was just a lot of good stuff. I mean, I learned so much and I just felt like it was huge of like understanding like what's going on. And I think it helped me. Not only was I learning, but I was also, because that's just how my brain works, right? As being in case management, doing what we do, and I think even just growing up, I was always a problem solver. It was for me, that's just how my brain worked. And so when I would look at something, I'd be like, how can I improve this? How can I make it better? So just learning about all of those things, it was really helping me to do that, right? And say, no, I think that this is what I need to do. I think I need to make it better. And so I think that I started doing some of that, and that was tremendous experience. And then the health plans, dealing with the audits and dealing with all of those things. And so I think that was just a whole another experience, right? Pulling paper charts and having them be reviewed, and what they were looking for and all the corrective action plans we had to do, because there was some things that they thought that wasn't correct, or what we needed to fix, and we had to respond to them with a certain amount of time. And then going into more right, even though I had done some but here I was doing more pharmacy right? So I was actually reviewing medication and applying criteria to what patients could not have and could have based on the information provided, right? So it was a very, very huge, learning curve for me from a lot of different things, because I hadn't been exposed to it. So, but I absolutely loved it. I think it was just a really, really good experience for me. And just, you know, eh, I mean, now I think everything's with the health plans is electronic, obviously, but and at the time we had to do paper. I'm sure you remember
We
those days.
definitely are timelining this, aren't we, with all of how much technology has advanced. I want to backtrack just a tiny bit, because I think you touched upon something that is, you used a term called custodial care, and I don't know that people really know that well, or know who it benefits, or know much about it. But I think it might be good to touch upon it now, because I think we'll be revisiting that in future podcasts, and probably getting into more detail. But I feel like it was an important piece, and maybe we want to give a little more context.
Yeah, absolutely. So custodial beds are actually it would be in the skilled nursing facilities still, but these patients would actually transition into, they would go, do their therapy, their rehab. And then after that, if we identified, for example, that the patient is really not safe to go home and they have nobody to care for them, they actually had assigned beds, a certain amount of beds in a facility that they could allocate to these patients to be basically living there. So that would kind of end up being their home. So when they're custodial patients there, that pretty much turns into their home. And so, and they just take care of the patient there, which was great, in so many ways. And that's what I was thinking, a lot of times that's where my mind would go, because, it was so limited in a facilities, that I was just thinking, how can we make this in a way where we could do more of this? How can we come up with this? You know what I mean? So, and I think that we were doing so much, learning as we were going through all this, right? I mean, I remember when we were getting remember when we were getting a contract for Aetna, and you had to write, I don't know, I don't even remember. So some ridiculous number, Barbara, but I remember that you had to write policies and procedures for, how many was it? Was it like 200 or something? I don't, it was some crazy number.
We had lost delegation with a health plan, and in order to regain the delegation, there's a specific amount of meetings weekly, paperwork, evidence that whatever the deficiency was that warranted them to pull the delegation, that we had to earn that right back. And so we put in the time and effort and energy, and put things in place operationally, and worked with the hospital. And we were able to show Aetna that we were able to take that work back and do it in a way that met the standards, not just only for Aetna, but something that reflected the company that we worked for.
Yeah, I remember all the policies you had to write. And I remember we ended up getting our delegation, and I was super excited, because I thought the amount of work you put into that thing, I mean, it was just crazy. And I remember we were so hands on, right? I remember it was just going to meetings at the hospital, all the collaborations, and going to the UM meetings, of going through cases that we, the complex things that we had to approve, and making sure that everyone was on board. And I remember just how involved we were, just to be able to provide the care that these patients needed, and advocating based on the information what we would receive. It's just pushing it through and pushing it through, and how exhausting it could be, but at the same time so rewarding at the same time, right? And I remember you being the person that came up with a post-hospital discharge clinic, and how you initiated that, and started it, and had our nurse practitioners see our patients after the hospital, making sure that, because we all know, right, it's such a critical time, in that time, right, that they're leaving the hospital, and then within 24 hours so much can happen within that time, that even though we think that everything's great and they're ready to go home, but so many things come up. But just that pivotal time of like between 1 to 3 days, that if things happen in that time frame, to be able to actually see the patients and provide care, was just, I remember it was just so impactful. And at that time, I remember nobody was doing it. Nobody was doing it. And how you were running that, and you initiated that, just unbelievable.
I think, for context, I originally started case managing the people that were repetitively going to the emergency room. And so we wanted to learn more about what was happening, why was it happening, and what were we going to do to fix that. And for more context, um, the company that we worked for at that time was one hospital, one IPA group, one medical group. So it wasn't an extremely large, but it was a very, um, they serviced a very, Whittier, it was a very large community, and there were definitely people who were in need. And so, my understanding during that time, the data showed that at that time, Whittier had the highest population of diabetics, and a number of comorbidities. And so the community needed us in a big way. But our medical director said, "What do you think? What do you think is causing this?" And when you get discharged from the emergency room, or you get discharged as an inpatient, and your aftercare instructions all come nicely printed. And it is the verbiage that I think is up for interpretation. It says, call your doctor in 3 to 5 days. Do you wait 3 to 5 days? Do you call after the fifth day? What if that's the weekend? Then you call on Monday. And so I think due to all that, and then how easy was it for people to get in to see their primary care doctor once they were discharged? And then also, um, the other piece is considering who is being discharged. If you're elderly and frail and sick, you don't feel well enough to go right to your doctor, and you might need transportation. So there were a number of things. And so I said we need to be able to see the patient within 24 to 48 hours. And I think we need to go to the home. And I think we need to also see how they live, because are they getting their medication? All of the things that we now know so much more about. But during that time, that was something um, people were not doing. And we started we called it post-hospital discharge clinic. So we started with myself and an NP, and we saw patients in the hospital to introduce ourselves, and we set them up with an appointment. And our nurse practitioner went to the home and assessed medications and all of those things, and they got care, and that bridged them back to their primary care doctor. And we kept a close eye on those patients, and we followed them for a bit until we knew we could let go of them, and there was some good work done there.
No, absolutely. I remember that. And so I think that, and as we go down the road, right, as we continue, I will come back and, we're going to touch base on that and elaborate a little bit more on that. Because we know things can always be better. It just depends on the game always stays the same. It's the players, right? So I think that that is the biggest thing in anything that you do. You have to have the right players to have success, right? So, but I think in a nutshell, that was our PIH journey together, right? And then due to some shifts and things that I'm going to verbalize this because I didn't agree with some of the things, and it's okay if I don't agree with it, because everything that I do has to align with what I believe in. And if it's not aligning with what I believe in, I'm not going to be part of that. That's just how I operate in life, and that's just what I do, and I believe in that wholeheartedly. So I think that for me, it just wasn't aligning with what I wanted to do any longer, and there were just some change and shifting in leadership, and um, we'll leave it at that. So I moved on, and at that point, I got a role as a case manager at Cedar Sinai Medical Center, and I was working with a lot of obviously Cedar Sinai had a lot of different groups at the time. They had medical group doctors, and they had IPA doctors, and then they had doctors that they were contracting with, so they were utilizing the systems for Cedars, but they were kind of their own entity, so they weren't really attached to Cedar Sinai per se. So I was actually, it was called the CI doctors at the time, and so I was managing their patients. And so I think the best thing was in case management with that is my role entailed seeing these patients in the hospital when they were admitted. So it gave me that opportunity to really connect with them. So now not only did they just know my name and my voice, but they actually put, connected the face to the voice and the name, right? So it was really just having that connection and having that support. And it was just a great experience. I would go to their appointments, advocating for them, making sure they understood everything that was going on. Because a lot of times, again, right, in healthcare, we move super fast. It's a lot of medical terminology. Sometimes they just get lost. They don't know what you just said, and they just go home and they're just like, well, I'm just going to take whatever the doctor said, and that's pretty much it. I mean, half of them don't even know the name of the medications that they're taking. So, but it was great. I started working on at the time they were building systems, and so we were building the system to assist the patients, like when we were taking assessments, to make sure that we captured everything that we needed to capture, as far as assessments goes, and what was needed and what we were identifying. And so for us to be able to put short-term and long-term goals together, right, as far as where are we taking this patient's journey in their healthcare, basically. And so I think it was amazing. I learned a lot. I was actually part of building the systems and helping them with just the assessment and what was crucial, and because I was calling a lot of patients and managing their care. So I learned a lot there. And then that's kind of in a nutshell what I did in but it was just building relationships, right? I mean, doing case management is building relationships. You tell them you're going to follow up with them. You make sure you follow up with them. So I think at that time, I think I had like over 200 patients I was managing. It was a lot, but I was able to kind of manage it in there based on their need and how many, there were patients that I had to touch every other day. But I was basically triaging them. If they would call me, I would, authorize procedures that they needed as an outpatient. So I was doing all of those things. So basically I was managing their entire care. And I think that for me, it was just such a big learning experience to build relationships when you're basically calling someone that doesn't even know you, and within a 5-minute conversation, you have to be able to build that trust for them to even want to talk to you. And I think that was a huge skill for me to learn, and to say, this is how it is, like, this is what I'm doing, this is why I'm calling. And and just having them go through that journey with me of what I'm wanting them to do. I mean, this is their life at the end of the day, right? It's their health. So yeah, but it was tremendous skill for sure. The most fun way to watch us is on YouTube, so be sure to like and subscribe. Also, you can follow me on Instagram, Facebook, LinkedIn, and listen on Apple and Spotify as well. If you would like to learn more about a specific topic, please reach out to us by email. You can find all this information below in the show notes.